It's my pleasure to welcome Dr. Torri Metz as our second keynote speaker. Dr. Metz is a professor of obstetrics and gynecology and a maternal fetal medicine specialist and vice chair of research of obstetrics and gynecology at the University of Utah School of Medicine. I just found out that she's also the new chief of her division of maternal fetal medicine, the Department of Obstetrics and Gynecology. Dr. Metz's interests include the treatment and management of women with chronic medical conditions that are complicating to pregnancy. In terms of research, she's interested in the impact of marijuana use in pregnancy on the mother and newborn, maternal congenital heart disease, and factors influencing mode of delivery. She's been awarded plenty of NIH grants recently, most notably looking at the association of marijuana use and adverse pregnancy outcomes, as well as she leads the study of maternal fetal medicine unit networks focused on examining the effects of the COVID virus on serious maternal morbidity and mortality. She's also a leading National Heart, Lung, and Blood Institute funded investigator who is looking at a longitudinal study on the post-acute sequelae of severe acute respiratory syndrome associated with COVID. And recently, she was appointed as the new editor of the Green Journal. So a whole swath of expertise that she brings today to share with us a topic that is near and dear to many of our hearts and controversial, to say the least. So thank you, Torri.
Thanks so much, Susan, and thanks to you all for being here today. I'm sorry I'm going to run into lunch. I know that is going to be unpopular, but we'll try our best here. And there is a natural break kind of when I start talking about breastfeeding. So if you decide you want me to break there and come back, I'm happy. Okay. All right. I don't have any conflicts for this presentation. So some of you may have heard me speak on this before, but I really just want to kind of review the more recent evidence and update what we know, talk about prevalence of cannabis use in pregnancy and reported reasons for use, how to counsel patients about the risks of cannabis during pregnancy and while breastfeeding based on the current data that we have, and then really recommend and utilize the available resources when counseling people regarding cannabis use in pregnancy and while breastfeeding. And I will say, it's been really interesting to hear, more of the neonatal and pediatric side. I know that most of you are on that side of things. But hopefully I can also talk with you a little bit about what we do in obstetric practice. So we know that cannabis is the most common illicit drug used in pregnancy. I realize it is legal in many places. It is not legal in other places. So we still categorize it that way for the purposes of looking at epidemiology. We do know that it crosses the placenta, and we do know that there's been increasing use with increasing legalization. So how much use is there? It's hard to say. The reported prevalence, honestly, in the literature ranges anywhere from 3 to 30%. The best data on this probably come from the National Survey of Drug Use and Health, or NSDUH, which is a cross-sectional, nationally representative survey looking at use over time. We saw 2.4% past month use in 2002, 3.9 in 2014, 4.9 in 2016. This continues to just kind of tick up. I think probably overall this actually underestimates use as well. I'm going to talk a little bit about how we try to find a proportion of use among pregnant people. And we know that when we actually do biologic sampling, which, I'm certainly not recommending in practice, but that we do see a much higher proportion than is self-reported. So there are a lot of data actually that come out of Kaiser, Northern California. You guys have probably seen this. If you follow this literature at all, Kelly Young Wolf publishes a lot in this area. She basically has this large retrospective cohort that she collected from 2009 to 17 at Kaiser of 280,000 plus women, where they actually did urine toxicology testing on every patient who came in for prenatal care. They found the incidence of use was around 5%, and self-report was around 2.5%. And that's pretty consistent in the literature. It's about 2 to 3-fold higher when we actually biologically sample. What they found is that being older, being of Hispanic ethnicity, and lower household income were all associated with misclassification of not using cannabis by self-report. So meaning that people who are older, people who are Hispanic, and people who had lower incomes were more likely to say they did not have use when they did. And that's potentially just because a lot of things we've talked about today, right? The stigma and concerns surrounding differential care when you report use. I used to work here in Colorado. And so some of you may recognize me from that time. That's when I really started doing a lot of this cannabis work, was when cannabis became legal in Colorado. Because all my patients started asking me, well, can I use it in pregnancy? And I'm like, I don't know. We don't know. And so I was very motivated to try to get more knowledge about that, push the research forward in this area. As we were doing that, we did a cross-sectional survey that actually happened here and at Denver Health, where I was primarily working at the time. And we looked at some paired samples, cord survey, and self-report. So basically took patients who'd come in, we looked in their chart to see if they'd reported use to a healthcare provider. We gave them a survey and said, hey, tell us about your use in the last 30 days. We're not going to tell anybody about it. It's anonymous. It's coded. Here you go. And then we actually sampled their umbilical cord to see if there was a cannabis metabolite. And here's the results. Basically, we found that only about 2.6% reported use to the healthcare provider, 6% reported use in the last 30 days on the survey, and 10% had a THC metabolite above the limit of quantification. Okay, and so that's what we use in clinical practice. That's a very conservative way to look at use, right? Because we really don't want to misclassify people with use when they don't have it. But really, you know, the lab, which is ARUP, which I think you guys are familiar with, is the University of Utah lab. It's a large reference national drug testing laboratory. Said actually 22% of these cords had some cannabis metabolite in it. And they're like, it is there. We just would never call it in a clinical setting. We just have to be really cautious about it. So, you know, at this time, you know, for it, freshly into legalization, we were seeing about 20% of the patients here in the Denver metro area with exposure. So we worry about, you know, evolving trends. What's happened during the pandemic is something that people have asked about a lot. We know that we've seen a lot of increase in mental health disorders in pregnancy and outside of pregnancy. We know we've seen increased rates of suicide. We know we've seen increased rates of drug use, all the things we've been talking about today. And this is another publication by Kelly Youngwolf, just looking at in California, they did see increasing rates of cannabis use during the pandemic. So why do people use cannabis during pregnancy? This is a question I get asked a lot. It's something I talk to my patients about a lot when they say that they are using cannabis in pregnancy. There are some data out there on this, but honestly, not a ton. I like this survey that was actually done a while ago within WIC. It's a convenient sample of 1,700 individuals, so not huge. But I think what's really valuable about these data is that it shows you that a lot of patients who continue to have current use in pregnancy, that middle column there, it's because they perceive a benefit of the cannabis. It's not that they're using it for fun or that they, you know, that for other reasons. It's really that they are perceiving that there's a benefit for them, most typically with depression, anxiety, stress, and pain, sometimes with nausea and vomiting. And so I think this just shows us as an opportunity to talk with patients about potentially safer alternatives. So what about nausea and vomiting? This is a hot topic in terms of use of cannabis in pregnancy. This is a publication that came from that Kaiser group, same cohort of patients, looking at universal screening with Eutoxin questionnaires like we talked about. And for this, the way they looked for nausea and vomiting was an ICD code for nausea and vomiting of pregnancy. They found severe nausea was present in 2.4% of their cohort and mild nausea in 15% of their cohort based on the coding diagnoses. I can tell you, like, as a practicing obstetrician, that's way too low for the amount of nausea that we see in pregnancy. You know, I mean, I have very few patients that come in and say I have no nausea. Certainly not everybody needs to be medicated, but I think this just speaks a little bit to the issues with using coding data for this. I don't code as a doctor, like most of the time that somebody has nausea when they come in early pregnancy. Of course they do. So I think we undercapture a little bit here. What they did find is that individuals who had severe nausea, vomiting in pregnancy and mild nausea, vomiting in pregnancy had increased odds of cannabis use. We also looked at this. We have some data that's part of the R01 that was mentioned by Susan. And you know what we really want to, and now we're taking that and doing a lot of work with this. So, and I was actually hoping another paper would come out before I came here, but it didn't, but it's coming soon. There's a paper coming soon that I'll give you guys a teaser for. But this is looking at some of that data. So what we did is actually biologically sampled anonymous samples. So no implications then for reporting. This is a big thing, right? We're trying to do substance use work and substance use research. We obviously don't want to increase any risk to our participants. And so all of the work that I've done essentially in this area has really been done with this anonymized sampling it later, not being sort of in this realm of mandatory reporting, to really just try to get information for patients. So in this case, what we did is we took urine samples from a large cohort of 10,000 women who had previously been enrolled in a longitudinal study where we were just getting information about pregnancy called the New Mom to Be study, and basically took those samples that they just submitted and froze many years ago and assayed them for THC metabolite. These patients also at that time filled out these puke questionnaires, which you guys may have heard about. It's a standardized questionnaire to sort of gauge the level of nausea that somebody has in pregnancy. And what we found in the patients who had THC detected, which is the black lines here in their urine, compared to the gray, which was undetected, was the people who had the THC detected had a lot more nausea, vomiting symptoms. So they had more severe symptoms. They had more hours of nausea. They had more episodes of vomiting. They had more episodes of dry heaves or retching. That doesn't, you can't sort out the chicken or the egg there, right? Did they use cannabis because they had these, or did cannabis create these? We can't sort that out. Nobody really can sort that out in a great way with the data available we have, but we do see higher amounts of nausea in these patients. So it certainly doesn't support the idea that we're treating it with the cannabis. So why, the other piece of this is not just why are patients using cannabis, it's why is there a perception of safety? And I would say that there definitely is a perception of safety. This, I think, is a really nice little research letter where they just basically looked at, again, NISDA data and asked patients, do you think that there's a risk of cannabis use in pregnancy? And I think that's what's interesting here is to see this uptake. So if you look at that first column from 2005 to 2015, no past 30-day use, people who are pregnant, the number of patients who reported that there was no risk with cannabis in pregnancy increased from 3% to 17%. And then among those that were using or had past 30-day use of cannabis in line in the column 3 there, 26% of them thought there was no risk in 2005, and 65% of them thought there was no risk in 2015. And so really these patients that are reporting this are saying, like, I don't think there's any risks to that. And I think it's reasonable that patients are saying that, because I'm going to show you some data to say that we're not talking to them about it. So it's not a surprise that they think that there's no risk. But if we're going to talk to patients about this, we need to know what the limitations of the data are, what the evidence says, and I think have a lot of honesty about we don't know all the answers about this right now. So I'm going to just review the literature, and I'm going to focus really on sort of more systematic reviews, more meta-analyses, because there are a lot of data out there. And I think that those are a nice way of just kind of summarizing what's there. But we have to recognize there's a problem with a lot of the existing studies that are out there. We know there's a lack of quantification and timing of exposure. We have difficulty adjusting for things like tobacco use, other drugs, sociodemographic factors, other things that influence pregnancy outcomes and offspring outcomes. And there's a really large reliance on self-report in the literature, which is a problem. We've already talked about that. It really underestimates use. And so people are getting misclassified as not having use when they did. And so that really causes a lot of issues with how we're interpreting these data. This is an old study, but I think it's interesting. It was completed in 1995. They looked at a prospective cohort of structured interviews and maternal serum toxicology screen. So patients knew they were being asked about drug use. We were going to do a drug test on their blood. And 70% of the people who had positive THC on their tox screen, which probably measures for the past 2 to 3 days on serum tox screen, said, nope, I have not used cannabis. They probably used it in the last 2 days. So it just really shows you the problems with this and the stigma associated with it and the degree to which individuals don't want to report drug use in pregnancy, which really complicates how we can do research in it and how we can talk to them about it. Plus, the data are old. Most of the data are old. A lot of this work was done in the 80s and 90s. Okay. So this is all the other stuff that was happening then. There were people playing like Pac-Man on Atari and MTV, and people were smoking in movies, and all that stuff isn't happening anymore, right? And the cannabis products are totally different than what was studied then too. They have much higher potency. They have, higher components of CBD. And so it's really hard to also take the literature that we have from then and even translate it to what we're seeing in patients now. So those are the limitations and the caveats, but let me tell you what the literature says. There's a few meta-analyses that have been done, okay? There were a couple of them were done around the same time in 2016 that sort of started this meta-analysis publications. One's by Gunn and colleagues, which is here, where they looked at any kind of outcome that was maternal, fetal, or neonatal up to 6 weeks postpartum that they could find 3 or more studies on, and then they did a meta-analysis. They found increased odds of maternal anemia, neonatal low birth weight, and NICU admission. And they said, geez, we thought we'd find a lot more on this. Actually, there's not a lot of high quality data and more studies are needed. There was another meta-analysis that really came out right around the same time that was a little bit more focused. They wanted to estimate if marijuana use increases the risk of adverse neonatal outcomes, but they really specifically looked at low birth weight and preterm birth. And then a bunch of secondary outcomes, which are you can read there. They found 31 studies total, 12 that focused on low birth weight and 14 that focused on preterm birth. And the pooled unadjusted data demonstrated an association between cannabis and low birth weight and preterm birth. And you can see those odds ratios there, relative risks there, 1.4 and 1.32. But after they adjusted for tobacco and other confounders, they said that association is not there anymore. The pooled relative risk, not 95% confidence interval now crosses 1. We shouldn't worry about cannabis anymore. Interestingly, in the same paper, they did a planned sub-analysis of people who had moderate to heavy use, defined as uses at least once per week, which isn't that much, right? But once a week. And they found it was associated with low birth weight and preterm birth when they did that sub-analysis. And these are the data that are actually cited in the ACOG committee opinion on this, saying that, people shouldn't use cannabis. We're worried that it has some adverse effects. I published with Laura Bergelt, who's actually a pharmacologist here at the University of Colorado, a review on this in 2018, which I think is a nice review for clinicians. It's really intended to be for clinicians if you guys have an interest in this work. And we put together the meta-analyses that are out there. And what you can see is, 1, right, is the line of unity. So if anything, any of those confidence intervals or whiskers are crossing 1, then you could say, well, there's not an association. To the right of 1, that dotted line is, yep, there's an association, and to the left, there's not. You can see that a lot of these things are crossing 1, right? Where we'd say, well, it crosses 1, we don't know, maybe there's not an association there. But I think the other thing that's notable when you kind of look at the data this way is that everything is to the right, okay? There's nothing that says like, oh yeah, this is good for you. So I think that, I think that's when we sort of think about, we have statistics and we think about sample sizes, but I do think we have to say, when we look at the data overall, we do see some concerns about cannabis use in pregnancy that we can talk with patients about. And in the bottom part, in that B part is where we start looking at differences in gestational age at delivery, differences in birth weight, differences in length and head circumference. Differences in birth weight is something that comes up over and over again with cannabis exposure. And I think there's pretty robust evidence now, if you look at it as a whole group, that we do see decrements in growth in utero with cannabis exposure. This is another meta-analysis that's come out more recently. This is in the slides. I know it's hard to read. Don't try to read it. But again, mostly what I want to show you is that we're seeing everything to the right again, right? So we're seeing that cannabis use is associated with low birth weight. It's associated with small for gestational age, those big diamonds on the bottom. It's associated with preterm delivery. It's associated with NICU admission. And so all of these things, we're seeing that there is an association when you kind of pool all the data that are out there together. So what about stillbirth? Stillbirth obviously is a really important outcome, especially to obstetricians. So you guys, do not see those babies, but obviously very devastating. There was a large case control study that was done by NICHD, the Stillbirth Collaborative Research Network, and they actually found an association between stillbirth and cannabis use when they actually assayed the cords for cannabis like we had done. So they biologically sampled with an odds ratio of 2.3. That's getting up there. That's a pretty high odds ratio and concerning for an association with stillbirth. After they adjusted for cotinine or tobacco use, is what they're adjusting there for there. It did reduce the odds ratio a little bit, but there was still an association there. Okay, so what about birth defects? We're just taking the whirlwind of things that obstetricians and neonatologists care about. So data are pretty limited and mixed on birth defects. There is an older study from the 1980s that didn't find an association with major malformation. I highlight that one because it's a large study. There's also been a number of large retrospective cohort studies based on birth defects registries, okay? The issue with birth defects registries, they have value, absolutely, is like these are the classic example of what we learn about in medical school of recall bias, okay? And so you have a patient, right? You call them 2 years after their baby's born, they have a baby that had a heart defect. And you're like, did you have any exposure to cannabis during pregnancy? And they're like, yes, because they walked through a parking lot and they could tell that somebody was smoking cannabis. And they walked right by there and they inhaled it. And so they were thinking about all the things that they could have done that caused this heart defect. And yes, they had cannabis exposure. Well, whereas the person whose baby's like totally fine 2 years later, do you have exposure to cannabis? Oh no, like I stopped as soon as I knew I was pregnant, which was, 10 weeks after the whole embryogenesis had occurred. So I think it's just hard. These are super important studies. They're valuable, but I think that we just have to also take them with a grain of salt. One of the best ones I can find that's out there came from the Atlanta Birth Defects Registry. The reason I say it's the best one is because they adjusted for all of these important confounders, right? So they adjusted for maternal age, race, diabetes, vitamin use, other things we know are important when we think about birth defects, which a lot of the other studies don't look at. And they found an increased rate of VSD in the cases that were exposed to cannabis compared to controls. But they appropriately concluded that more data are needed. And they said there's just not adequate evidence of an association with any specific congenital birth defect. We found this, other people need to look at this, and there really hasn't been a reproduction of that. There was a recent systematic review that just got published looking at anomalies in cannabis exposure in the Green Journal. There were 11 studies. There was a pooled adjusted odds ratio for any type of anomaly of 1.2. So just barely hitting that 1, right? 1 to 1.5. And they said the two things they found that were associated were Epstein anomaly and gastroschisis. But they said these studies are super heterogeneous. There's a really high risk of bias. The evidence is really inconsistent. Like, we don't know the answer to this. We need more information about this. So I just want to briefly highlight paternal cannabis use. I think we talk very little, and I know I've heard some of that today, which is great to be thinking about sort of the whole picture when we're talking about these families. But, we don't focus as much on paternal cannabis use. There are growing data that there is likely a role of paternal cannabis use that affects offspring outcomes as well. There's some data suggesting it's associated with lower birth weight, miscarriage, and SIDS. And there's interesting data coming out looking at sperm DNA methylation and genes involved in neurodevelopment and autism spectrum disorder that have demonstrated some association with changes there that affect downstream consequences with cannabis exposure surrounding the time of conception. Okay, so what about neurodevelopment? I've heard it talked about a little bit today, right? That we do see an effect. We worry about neurodevelopment in babies who have exposure both in utero and then subsequently. I think that these data are really tricky, and we'll talk about why. But the animal data is helpful here too, because when you're talking about neurodevelopment, there's so many other things that go into neurodevelopment in these kids, which you guys know very well. When we look at neurotransmitter models in rats, we do see that there's affected dopaminergic pathways with cannabis exposure. And when we looked at post-mortem human fetal brains, Yasmin Hurd, who did a really nice study, she looked at elective terminations between 17 and 22 weeks, and they found that dopamine receptors were reduced in cannabis-exposed fetuses, most prominently in males, and interestingly directly correlated with the amount of cannabis used during pregnancy. And I think, these patients were probably more likely to self-report use. There's less stigma and bias, right? They're planning to terminate the pregnancy. They really just wanted information about exposures at that time. And so seeing this direct correlation, I think, is interesting. There are some human studies looking at this. There's 3 main ones that are the big ones. There's one out of Ottawa, there's one out of Pittsburgh, and then there's the Generation R study out of the Netherlands. These studies are very different, and I won't go through all of the details here. You guys will have access to the slides, but the populations are very different in these studies. But they took these kids and they followed them over time. And I have to say that the big caveat here is the data are limited by confounding, okay? These children who are exposed to cannabis have very different, lots of things, right? If you look at all the demographic characteristics of their moms, of their home environment, of where they live now, what has happened in their life, it's totally different pathways in a lot of cases that is really hard to make them look the same at baseline to then say, oh yeah, this is cannabis and not any of these other things. Okay, so these are limited by confounding. The Ottawa study found no differences between groups below age 4, but at age 4, they started to see increased behavioral problems, worse language comprehension, decreased sustained attention and memory. And the Pittsburgh study saw decreased verbal reasoning at age 6. worse academic performance at 10, and increased substance use at age 14 after accounting for ongoing parental substance use. In the Generation R study, they found higher aggression scores in cannabis-exposed girls, but not boys at 18 months. No differences in behavior at 3 years of age, and ongoing follow-up into adulthood for children born from 2002 to 2006. So they're continuing to follow these kiddos. This is a relatively recent publication that came out. I guess 2020, geez, time flies. I guess 3 year ago publication that came out from the ABCD study, which I'm sure a lot of you are familiar with. They found that 6% of their population was exposed to cannabis prenatally. That's getting close to, I think, what the population prevalence is, which is probably in the range of 7 to 10%. Keeping in mind, these are patients that have enrolled in a prospective longitudinal study, probably may potentially see a little bit lower rate. So 6% is probably right in there. They found mean age at follow-up at 10 years, and cannabis exposure after maternal knowledge of pregnancy was associated with greater psychotic-like experiences, externalizing attention, thought, and social problems. So the National Academy of Sciences has gone through all these data and said, this is what we think is important. We've reviewed all the evidence. They put out a publication on this. You can find it online if you just, Google National Academy of Sciences cannabis, and it will come up. There's a whole chapter on pregnancy and breastfeeding. And so if you guys are interested in this topic, I'd recommend you take a look at it. They did find a consistent association between cannabis use and lower birth weight in the offspring. I do think that is pretty consistent in the literature now. They found limited evidence of an association between cannabis use and NICU admission. And they said insufficient evidence of an association between cannabis and neurocognitive outcomes. And the reason they said that is because they said we cannot adequately adjust for all of these environmental differences. Like, it's just not possible. And so it's not that you wouldn't see that association in the literature. It's not that people don't think it's biologically possible, but this report just said, we just can't say that. We just don't have a way to adjust for all these things. ACOG, the American College of OBGYN, says people should not use marijuana during pregnancy or while lactating, and that OBGYN should not prescribe for medicinal purposes to pregnant or lactating individuals, and that there's insufficient evidence for effects on the nursing infant. And we'll get into that a little bit. So how are we doing now? And I think that's a lot of the focus of what I've heard this morning is like, how are we taking care of patients who have substance use? How are we talking to them about it? How are we supporting them in terms of their parenting? And their answer is that we are not doing a good job of this. And so it's great to see so many people here engaged in this work. This is a little bit older study, but I think is super interesting. It came out in 2016 by Holland and colleagues. They recorded actual patient prenatal care encounters and evaluated the obstetric provider's response to disclosure of cannabis use. And what they found is this was a high prevalence of use population, 19% reported use at their intake. To 47 different healthcare providers. And this was in Pittsburgh. And 48% of the time, the provider did not even respond to the disclosure. Just went on to the next thing. Do you use cannabis? Yes. Do you wear your seatbelt? It's just not like, that's not helpful. Like, this patient has just disclosed something to you that we can at least talk about, right? And when it was discussed, the response was really nonspecific, focused on urine tox screens, punishment, social services, right? So again, not helpful and not creating any kind of therapeutic relationship. This is a quote from one of the encounters. Do you know how it alters your mind when you have it, how it makes you feel? So think about what it's doing to the baby that is not even formed quite yet. It gets the effects as well. And we don't want to do that to the baby. I mean, if I'm a patient, I'm like, I have no idea what this person's talking about, right? This is vague. It's not helpful. It's not any kind of a therapeutic or helpful relationship. This just came out. It's a cross-sectional study of PRAM's data from 2017 to 2019. They looked at prenatal care visits in 8 states. 2 of them had legal cannabis, 10,000 people. 37% of them said they were not even asked about cannabis during their prenatal care. 63% of them said they were not advised against using cannabis. Of those that reported cannabis use, 50% were advised not to use it in pregnancy, only half. So pretty similar with that Holland data that I showed you, that qualitative data. And interestingly, almost 8% were advised to use cannabis at their prenatal visit, which is, it kind of blows my mind. We have to talk to patients about this. I don't know if you guys remember this study when it came out. It got a ton of press when it came out. We did this here in 2018. We did a mystery shopper study called 400 randomly selected dispensaries here in Colorado. The caller said she's 8 weeks pregnant with nausea, and 70% of the dispensaries had a product recommendation for them. They predominantly recommended edible products. 65% of them based that recommendation on personal opinion, meaning they said, well, personally, or I mean, in my opinion, or in my experience. That was the kind of leader that labeled that as personal opinion. And only 32% of them recommended discussion with a healthcare provider without prompting. We have not repeated this study. There was a huge ruckus in response to this. This was not good. Cannabis dispensaries are not supposed to be doing this. There was a lot of education that went out. And so my guess is that this is better now. But we do need to talk to patients because other people are talking to them. CDPHE, as you guys know, has done a great job in terms of providing pregnancy and breastfeeding guidance. These are the most recent handouts that I could find online. They had been adapted since the time I had worked on them while I was here in collaboration with them. I mean, I think if nothing else, you don't have time to talk to the patient. I get it. You have 20 minutes to do all the things in a prenatal visit. At least just give them a handout. Oh, really? You're using cannabis? You know, we don't recommend that. Here's some information about it. Let's talk about it. And sometimes that's all it takes. Honestly, like a lot of patients that I take care of are like, oh gosh, I had no idea. I can just stop. And that's not true for everybody, but like we need to at least have the conversation. Okay. So this is where we transition to breastfeeding. This is short because there's not much data, and then we can have lunch. THC metabolite does pass in the neonate in the breast milk. I'm sure you all are keenly aware of this. Initially, these data were based on a letter to the editor in the New England Journal of Medicine of 2 patients, one of which actually had data that said that her chronic heavy use could result in levels up to 8 times in the breast milk as compared to the plasma. That is one patient, guys. So I hear this repeated a lot, and I just want to emphasize that like we have a long way to go in terms of studying this. And I want people to understand when they're saying that, they're basing that on one patient. There's a little more data, and some of it has been collected here, and I'll get to that study next. But this was a study that came out. This is 8 patients. So we're going up, right? So now we have 8. These patients actually purchased a product with a known concentration of cannabis here in Colorado at the dispensaries. They went to a specific one, got a specific product, sent their samples to Texas. They were told that they should abstain from use for 24 hours prior. They were then told to inhale the cannabis, collect their breast milk at 20 minutes, 1, 2, and 4 hours. And then they did that. Okay. So here's what we want you to do. We want you to go get some cannabis. We want you to get really high and then try to do this really specific protocol and then send us your milk. I mean, there's issues, right? But still, we're up to 8. We're up to 8 patients here. And what they found is that an exclusively breastfed infant ingests a mean of 2.5% of the maternal dose. So yes, it crosses in small amounts, and it's measured only in the milk. They weren't able to measure actual absorption in the neonate, which is probably a little less, right? This is another study that came out in pediatrics, 54 samples from milk donors. Delta-9 THC, which is a metabolite of cannabis, is detectable in 63% of the samples up to 6 days after last reported use. So we do see persistence of metabolite in the milk. Unfortunately, right? We can't say, oh, if you just pump and dump, like it's fine. The median concentration was 9 nanograms per milliliter. And of course, the number of daily uses and the time from sample collection to analysis were predictors of the concentration of the breast milk. Of course they are, right? The more use there is, the more frequent it is, the more you're going to have metabolite there. But I think that lends validity to the data that they have. Okay, so this is Erica Weimer's study that I'm sure you all are familiar with since she's here. We looked at, we did a prospective cohort study to estimate time to elimination of cannabis metabolite from the breast milk. 25 people, you'd think, oh, that'd be easy. This was not easy. I'm sure Erica has told you all. One of the inclusion criterion was a plan for abstinence. So we said, please do not enroll in this study unless you plan to stop using cannabis today. Oh, I'm definitely going to stop. Half stopped. Okay. So this is part of the issue, right? I think sometimes patients feel like, oh, I can stop. Oh, actually I can't. So only half stopped. These patients were primarily inhaling as their mode of consumption during pregnancy, more than 2 times a week. So heavier use patterns. And we found detectable THC in the breast milk in all participants during the 6-week study period, just present. Overall, 402 serial samples were analyzed from these 25 participants. The half-life was 17 days. The projected elimination was more than 6 weeks. So again, this is this issue with like, we can't just tell patients, oh, we'll just pump it up. It's just not realistic, right? To tell a patient like, oh, just do that for 8 weeks and it's gonna be fine. And then you can start breastfeeding it. That's an impossibility for a postpartum patient. So what do we tell them? We tell them that there's no known benefits of cannabis use in pregnancy, right? Oh, I think it works for nausea. Well, it looks like it doesn't. And all the data shows that it's actually more, people have more severe nausea when they're using it. That there's possible risks of cannabis use in pregnancy. I think we can say pretty clearly that we see decrements in fetal growth. There's also non-human primate data demonstrating that. And so I think that's helpful to kind of back up that idea that that's probably a real thing and isn't sort of a result of all these confounders that we've talked about. And that there's an increased risk of stillbirth, maybe an increased risk of NICU admission, maybe an increased risk of downstream neurodevelopmental delay. And that's what I talk to my patients about when we're kind of talking about these things. I advise them not to use cannabis during pregnancy. We don't know of any known safe amount of cannabis in pregnancy and while breastfeeding. There's a lot of research opportunities that we've highlighted here. Okay, so congenital anomalies, I think we still don't know. The data are pretty mixed, heterogeneous. This is something that patients really care about. I like in OB practice, I can tell you that's like one of the main questions we get. Well, does it cause birth defects? So they're talking about cannabis, the medications that they need to use for other, complex medical disorders. That's a huge thing for patients. So I think that's important. That's a gap. We need to address it. NICU admission, we're seeing these signals, but there's not a great described syndrome of cannabis exposure in terms of like withdrawal, like we have for opioids. And so why are these babies having an increased risk of NICU admission? Where is that coming from? What's driving that? I think we need more information about that. Long-term neurodevelopment, try that as rigorously as we can, which certainly those 3 studies that I had mentioned have done, to really adjust for all those other things: ongoing use, ongoing exposure through breast milk, ongoing exposure through inhalation in the home, just differences in environment, continuing to really try to sort that out. And then improved ascertainment of exposure. So we really need to understand dose, duration, and timing of exposure. Those things are critical when we're talking about research and evidence to be able to counsel patients. If we don't know those things, it's really hard to like sort out what to tell them. If we're talking about congenital anomalies, all I really care about is exposure in that, periconception and early pregnancy period. A lot of the work that I've talked to you guys about today has been funded work, initially actually through the University of Colorado CCTSI Maternal Child Health Junior Pilot Program. I was then on a K-12 Reproductive Health Scholar Program here, and then have a NIDA R01 where we are looking at dose, duration, and timing of exposure. And that's what I was like, oh, maybe it'll be published, and it's still close, but coming soon to a journal near you. So thank you guys so much. I did kind of the whirlwind tour because I know lunch is in order, but I really appreciate your attention and engagement, and I am happy to answer questions later when we have the session. So thank you so much.
All right. Oh, I'm sure you guys have no questions after that talk, right? Oh my God. I'm almost afraid of the Q&A session that we're going to have during lunch, but we are going to proceed to lunch. So please grab your lunch, come back, and why don't we say at 1:45, we will have the Q&A session for about 15 minutes with both of our keynote speakers, and then we'll have the presentation from our Poudre Valley Hospital. You all one mic
All right.
to share.
Oh, you know what? I don't want to, because I've been wiping my eye.
Yes,
Yeah,
so
I
you
had
will
this
not
eye
share.
crud.
Okay.
Yeah.
Yes.
Yeah, I'm
Sit
sorry.
a little further away. You
Right.
can't. Sure.
Yeah, I don't think it's good because I have cornea transplants and I have like this leaky eye thing.
All right, guys. I hope you all have gotten your lunch. This is like the grade school approach to getting everybody's attention. So as I promised, we wanted to have a question and answer session before we have our presentation from the Poudre Valley folks. These were 2, jam-packed keynote presentations that we heard. And I have no doubt that lots of questions I'm sure are in your mind. So I wanted to make sure we had about 10 or 15 minutes to give you the opportunity for comments, questions, concerns. So we have the mic for both of the speakers. So if you have a question, just like scream it real loud, and then I will reiterate the question so that those who are joining virtually can hear it. So questions. I'm going to start us off for Dr. Young. So we have no shortage of information related to, policies about plans of safe care, family care plan. We've got lots of different names for that. What oftentimes we get frustrated by many in this room are all the questions that you posed about how this is actually done. How do you actually operationalize these policies, these laws, and in our mind that are passed at the state and at the federal level. And so while it seems as though there's some energy and funding that comes along with some of this legislation, I feel like that does not trickle down to the people that are trying to operationalize it. And just curious to hear, how we think about bridging that divide. And it sort of goes back to the comment I made this morning that many of us know what to do at the bedside, but you tell us, stuff that's happening in the legislative arena, it's like this faraway thing. And we're not quite sure if the folks in that faraway place understand what's actually happening at the hospital. So the example that I'll provide is at the University Hospital, trying to implement plans of safe care for quite some time. And frankly, what has happened is that if a baby that was prenatally substance exposed ends up in the well baby nursery, their plans of safe care completion looks very different than, say, a baby that goes to the NICU, where most of the NICU infants are high-risk infants. And there's a process in place to ensure that these sort of a plan of safe care like thing actually gets operationalized, that there's a case manager, there's a social worker to help with these referrals. Where in the well baby nursery, at a delivery hospital that has 5,000 babies a year, to expect that hospital to operationalize the plan of safe care as you have it is nearly impossible. And yet we don't hear from the people that are making the rules and the laws about how you take the language in the law and translate it into practice. So curious to know, to hear your thoughts related to that.
So there's not a lot of money in the Child Abuse Prevention and Treatment Act. When the Congress changed the statute in 2016, the appropriators added $60 million for the entire country. The captive state grant before was only in the about $26 million. So it was a huge increase, but $60 million to implement plans of safe care across the country in 50 states. I mean, one state could eat that up. So it didn't come with money. So that's part of the issue. Some states have like a part-time coordinator who's handling all of this, trying to get things implemented. So what that means is it really relies on those partnerships. And I can't emphasize enough. I think I said it, probably 100 times in the 50 minutes that I spoke. It has to be done before the hospital. The hospital is just way too late. Hospitals are implementing when it should have been done by whoever was taking care of this person before they got to the hospital. And unless it's that partnership to really do that, then it is incumbent on the hospitals. And that should really be those that are like, person showed up, no prenatal care, the family that we really have a lot of concerns about, that didn't engage in services. Those are pretty small. They're really small numbers compared to if we had moms who are in treatment and the treatment provider helping and coming to the hospital with that. One of the best stories I ever heard from a parent was a couple that were part of the Hushabye nursery program in Arizona. And we asked them to speak at a meeting that we were doing. And this NICU nurse decided that she was tired of seeing all of the babies coming into the NICU, and she was going to go talk to the OTPs, the opioid treatment programs in Phoenix. And they together developed, they called it a green binder. They developed their green binder, and she started a weekly group for parents that were on methadone or pregnant persons on methadone at this opioid treatment program. And the green binder became known as, that was their plan of safe care. So when went in for delivery, the father told the story of they went in with their binder, they had their plan, they knew that child welfare was going to be called. So they had their plan, they had their binder, they knew everything, that all the services that they had participated in, all the safety plan that they were putting in place in their home. And he said, we couldn't wait for the office to open in the CPS office. So we could call them and tell them our baby's come, we have our plan. That's pretty revolutionary that the parent was encouraged to say, call CPS, let them know you delivered. Baby may go through withdrawal because mom has been on methadone and that might happen. And you may get a call, but I want you to know we have our plan.
Mm.
Those kinds of partnerships. Now, what does that take for a hospital to do that? That takes the hospital really being part of the convening of the treatment providers, the court, the dependency court, the juvenile court has to be at the table. The attorneys for children have to be at the table. Everybody has to agree. These are the things that we're really concerned about, that we're going to have CPS involved. And these are the families that are stable. We're not as concerned about, don't have immediate safety threats. And these are the indicators to know that about what's in that plan.
Mm.
Does it happen? It happens. Does it happen across the country? No. That's why there's a whole movement. I don't know, can't call it perhaps a whole movement, but some people that are very adamant about repeal CAPTA, completely get rid of CAPTA. I'm not on that side of the fence. I think that places like what you're doing in the pilot here, what you've done in Colorado, other places that have put these implementation plans in place are doing good practice and helping young families.
Mm.
Long answer, sorry.
It's a complicated issue. Other questions? Yes.
About the breast. So we obviously know that, if someone's using, their partner's probably using, their friends around there, the kids that they're using, and I'm just wondering, do we have an idea if cannabis or THC and treatment to breast milk is as harmful or more harmful than just for smoke?
So I'm going to repeat the question for those that are joining virtually. So the question is, root of cannabis exposure and whether or not we can differentiate the birthing individual's use of it versus another person or in the environment.
Yeah, I think that's a great question. I mean, nobody knows the answer to that. I mean, I think that's one of the things that's really tricky about the assessment of sort of this any of the neurodevelopmental outcomes down the road, right? It's the exposure in the home, it's the exposure in the milk, it's the exposure in utero. I didn't cover it just because there's only so much time, but there are some studies looking at neurodevelopment after in utero exposure or breastfeeding exposure. And basically they're like, I can't sort that out. Most patients, and, you see that in Dr. Wymore's study as well, even if they want to abstain, as they begin breastfeeding, they weren't able to. And so really sorting out those differences, I think, is a challenge. I mean, I think just like anything else, we're going to tell families, right, that minimization of exposure to neonates is a goal, right? Whether that is minimization through, not using in concert with breastfeeding or not using in the home. I mean, it's the same, I think. I mean, I'm like out of my wheelhouse because you guys are on the pediatric side, but I know that when I go and take my kids to the doctor, is there exposure to smoke in the home? Well, no, there's not. I mean, so, I think we're always doing that. I think from a public health mitigation standpoint, from a data standpoint, people have not sorted that out.
Other questions? I'll follow up on that question, Torri, around cannabis. So it sounds like if I were to kind of hone in on the take-home message, you feel like there's enough epidemiologic evidence around cannabis use during pregnancy and low birth weight. That feels pretty good. We could say that. All of us can go out and say that to our community. Okay. Anything else that we could say with some assurance?
Yeah. I mean, I think that's hard. I mean, I think we have one study on stillbirth, right? So it's always hard to kind of pull a lot from one study. I will say though, that study was rigorously done. It was done with, biologic assessment for THC metabolite. They adjusted for important confounders and they still found an association. So I do talk to my patients about that. And I say, like, I'm very honest with them. Like, this is one study, but this is what this one study said. That's an important outcome, stillbirth. I think the other piece of it that I tend to counsel about, and I think that people will continue to counsel about, is that we do see an association between cannabis use in pregnancy and adverse neurodevelopmental outcomes down the road. I think that where we get into the confusion, where National Academy of Sciences wasn't willing to say, like, this is definitely cannabis, or cannabis in utero, actually, is what they weren't willing to say, is because of all this other stuff, right? Well, what if it was like, because then the neonate's like at the house and there's smoke every day, and how do we sort that out from the in utero exposure? And so, but I still think it's something that we can put on people's mind and it's biologically plausible, right? And that's why people have looked at this in the first place. You know, the endocannabinoid system is very active in both placental development, which is why we think that we probably see this effect on growth, and fetal neurodevelopment. And so it's not surprising that we'd potentially see aberrations in those things as we introduce exogenous cannabis that shouldn't be there, that can potentially disrupt these processes. And so, you know, I talked to them about growth for sure, stillbirth, concerns for ongoing exposure and neurodevelopment, especially later in pregnancy when we're really having a lot of that fetal neurodevelopment.
Yes.
I'm assuming that all the studies decided exposure was cannabis only. So the preliminary results of that funding, I don't know, I'm not calling that. But what was scary about that legalization of cannabis in the United States is that it wasn't 1+1 on the exposure, it was exponential. So the combination of alcohol and cannabis, the impact on the development baby was exponential.
Yeah.
I don't know, Ryan, or do you want me
Oh,
to-
can you? Yes.
Okay. I think the question is really just sort of looking at potentially synergistic effects, and can we really isolate cannabis from other things like alcohol, opioids, cocaine, any of the other tobacco, you know, any of the other exposure we talked about. I mean, we know that there's very common co-use, especially of tobacco products and cannabis. And so there's been more attention, I would say, to that in the literature than some of the other co-exposures, although clearly alcohol is an important exposure in pregnancy as well. It's just a little harder to measure because it goes way faster in the urine and the other places we try to measure it. But there are some people and there are some data that would support the fact that tobacco and cannabis are synergistic in causing adverse effects. We certainly have looked at it in our studies. I can tell you that with the exception of tobacco, the other exposures are so low, it's really hard. They don't end up sort of playing in. And it doesn't mean that they don't have an effect. It just means they're hard to study because exposures to other drugs, you know, cocaine, amphetamines, are low enough that it's hard. Opioids is becoming, you know, more and more common, which obviously we've talked about a lot today. But I think that that's the issue too, is just sorting through those things. What is it? I think, you know, cannabis and tobacco are by far the most common exposures that we see. And I think what I sort of tell patients and what I want to support is that, you know, we do talk to patients about alcohol and tobacco and pregnancy. Everybody does. It's like a common thing. You see the posters at the bar, right? Alcohol use is associated with bad things in pregnancy. If you're pregnant, you shouldn't drink alcohol. We don't see that same kind of public health messaging surrounding cannabis. And I think it's like super important to not say we're doing this to blame people or stigmatize people, but I mean, I think patients just want education. Like, we just need to talk to them about risk. That ultimately it's up to them to make decisions about what they want to do. But, you know, as clinicians, I feel like our responsibility is to at least open the conversation. Like, the idea that people would disclose and 50% of the time we wouldn't even talk to them about it is like crazy to me. You know, they're trying to have a conversation with their clinicians about it.
All right. Last question. No, go for it.
State money as well. the marijuana exposure, you know, what is conceptualized now as a symptom of other, you know,
Well,
We'll repeat it.
we repeat the question after. Yes.
well, you know, we sometimes think about reconceptualizing the occurrence of prenatal or early prenatal exposure as, you know, indicator of mental health or poverty or, you know, other stressors or other things that it's serving a function with. And so I'm wondering, have you ever seen any early start programs or anything like that that really tries to shift the way we conceptualize substance exposure as a symptom or a marker or indicator of these common collection of, you know, other cultural factors? And so I just feel like there's so much focus on the teratogen or the exposure itself, and, you know, why is it there in this situation and not over here? And have you seen people really trying to do that? And is that impactful? I mean, is there a fear of, is there a consequence to moving away from just the, you know, substance exposure itself? You know, I mean, yeah.
So so I could,
Yeah,
I can kind of
paraphrase
try to
that.
distill that question. I think it's a question of what's upstream and downstream. That really your question gets at, why are we focusing on the downstream outcome of substance use and perseverating about that, when in fact there's a whole host of upstream factors, other social determinants of health, other things that are leading to or are risk factors for substance use. So are there policies, you know, what's happening at the state or federal level, thinking more upstream instead of just perseverating on the substance use itself?
So what comes to mind for me is the women and co-occurring disorders study that was, I can't remember now how many treatment agencies participated in that, but they looked at the history of women who were using during pregnancy, got into treatment. The ACE scores of that population is extreme. I tried to say that in this, living in a home in which there's substance use disorder. In the 1970s, a guy named Timothy Renovis, I think is how you say his last name, and it was Children of Chemically Dependent Parents was the name of the book. And it was so remarkable to me. He said there should be a DSM code for chronic trauma of childhood, and that kids who are living in with families with substance use disorders fit into that chronic trauma of childhood. So it's not unusual to have, you know, somebody who is documented, you're at higher risk of developing your own substance use problem if you're living in that family. The ACEs that show, you know, mortality and morbidity, they're highest for those characteristics of children that are living in this chronic trauma, somewhat chaotic environment. Is every substance use disordered family that way? No, absolutely not. But it seems to be additive. So I think what you're saying is, are we getting to this kind of childhood experience in prevention of this child that would go on to have their own substance use disorder? I think there's a lot of effort going on there. I don't think that it combines the issues of what's happening for that child who may be FASD, have neurodevelopmental effects of prenatal exposure, and they're also living in these home environments that would produce a higher likelihood of them having their own problem. So I think you're kind of asking, where do we get off the merry-go-round and stop and say we need to start here with prevention efforts in this population? And for me, I think that is all the work that you're doing, and making sure that those kids are connected to early intervention in a way that helps them through those primary grades and gets them the services that they need for all that sensory integration, all of that piece that they're executive functioning, all of those pieces that they need to have intervention really early on.
Thank you. Thank you to you both. We really appreciate your expertise.